Olivia? Hello. Hello, Olivia.
Hello, doctor.
So, are you going to introduce myself or should I just go and start?
Now you could introduce yourself and also you could begin your presentation.
Okay,
Okay,
perfect.
thanks. See you later.
See you. So, hello to everybody. Welcome to this session today. I would like to thank Good Picker for inviting me to be here today sharing my knowledge and this presentation about lasers. Sorry, because I want to go to the screen. Let's see if I can share the full screen. So my name is Vanessa Ruiz Magat. I'm from Barcelona, and I'm an associate professor at UIC at the Universitat Internacional de Catalunya, and also a visiting professor at the University of Padova. So I would like to start saying why I do love lasers. And the history starts 20 years ago when I was a student of dentistry and I went to a lesson in this hospital. It is very nice because with the years I'm working since 14 years now in this same hospital in Barcelona, in Tecnon Medical Hospital, where I'm also using there this Good Picker diode laser for my periodontal treatments. Years ago, I also presented in 2015 my PhD work, and it's also about lasers, in this case about erbium chromium YSGG laser. And let me show and share with you today why I do recommend to everybody to have a diode laser in the dental clinic, because it can really help us in many treatments. So the diode laser has many indications in the periodontal field. We are here today reunited thanks to this man, this doctor, Professor Albert Einstein, that developed the theory of the laser light. And the laser light is a sort of special light that is covering, monochromatic, and also collimated. And it has several effects when it's reaching a surface. It means a tissue, a biological tissue, because we are dentists and we are treating tissues in the oral cavity. So when we have a laser irradiation, the main effect is the absorption in the tissue, in the main tissue, where we go with our light. But we also have some other effects like the reflection and also the scattering and the transmission. So the coefficient of absorption depends on the soft tissue components. This means that it depends on the concentration of water that the tissues has, and also the proteins, other macromolecules, that something which is utmost important in concerning diode lasers, it's the pigmentation of the tissues. And this is very important because diode lasers love to be absorbed in tissues that are of a dark color, like for instance, the blood. The blood is a tissue, and this laser likes to be absorbed by blood and also by some other tissues that contain a high concentration of water. So due to the reflection, it is also very important that we protect our eyes while we are using this wavelength of lasers, diode lasers, because if not, we can damage our vision. And let's go to talk about what is a diode laser. A diode laser is a solid-state semiconductor laser, and it changes something very important, that changes electrical energy into light energy. And this light energy has several effects. In general, the classical or the most common diode lasers are emitting at 8, 10, and 980 nanometers. Nevertheless, the woodpecker laser has 3 wavelengths in just one device. So we can say that this is a new generation of diode lasers. And what can we do with these 3 different wavelengths? So with the 976 nanometers wavelength, we can go for disinfection of periodontal pockets and also for degranulation and detection of curettage. When we work at 450 nanometers, this is when we would love to go for soft cutting, soft tissue cutting, and also for coagulation. The coagulation issue is very similar to the electrocauterization. Nevertheless, at an histological level, it's quite different, even if it looks the same when we are clinically working. So we can say that the diode laser is much more friendly for the soft tissues. And the last one is the 650 nanometers, and we work or we choose this sort of wavelength when we would love to go for biostimulation and also for pain relief. There are in this laser, the woodpecker one, several technical parameters that I'm pretty sure that you can go for in the market and check in the internet. But what I really would love today to show you are the applications of these lasers. So I will briefly comment why to use during the non-surgical periodontal therapy with just few slides. So this sort of laser can be used in a low or in a high intensity of mode. When we are using more than one depth, means that we are using a high intensity, this diode laser, and we are aiming to have a bactericidal effect, some thermal desnaturalization, and also a direct effect on the tissues. We need to know that working are more than one bed, we can also have some undesirable side effects like an excessive ablation, thermic coagulation, and necrosis or carbonization of the root, the connective tissue, the lamina propria, the bone, and the pulp. So this is something that to take into account when using diode lasers at more than one dot. So this means that we can refrigerate our tissues just by irrigating with saline, or we need to work with the touch screen of the laser, work with the program and let the tissue a bit of time between applying some energy and the second period of energy. And what can we do? When we are doing a scaling and root planning, this laser does not serve to eliminate the calculus. This must be done with a traditional curette or also with ultrasonic instruments. Nevertheless, if later on we irrigate the pocket to eliminate this bleeding and we apply the fiber, the optical fiber of the laser, we can disinfect the periodontal pocket. So this light, this diode light, has a direct ablation towards the bacteria, the gram-negative bacteria that we have in the most apical part of the pocket. We need to redo this action by using the correct, the ultrasonic instruments or devices, and then go for a second application of laser moving apical to a coronal direction. What does the literature say about these lasers? That they help us to reduce the periodontal parameters like the clinical attachment level, the probing pocket depth, and also something which is very important, that is to reduce the bleeding on probing. And we know that this parameter is utmost important in periodontology because in areas that are bleeding in 30% of the cases, they are associated with a loss of attachment, clinical attachment level more than or higher than 2 millimeters. So if we can go and work with the laser, this laser can contribute to reduce this BOP in our patients, and this means to reduce the risk of losing clinical attachment level. Let me show you this case in a patient that couldn't take antibiotics and was treated with traditional instruments, curettes, and ultrasonics, and then the patient was receiving a session of diode laser, and this is the result. Some weeks later, when we took the patient for the re-evaluation. We can also use these diode lasers with the 900 nanometers light for a low-level therapy. This has a direct effect against the bacteria, and it does not have the side effects that we had before. This means that it does not create any damage into the patient's tissues, like the root, the connective tissue, the bone, or the pulp. This is named, or you can find this information in the literature, called antimicrobial photodynamic therapy. And when we use this therapy, we need to use something that has a dark color. I have said at the very beginning of the presentation that this laser, the diode laser wavelength, is absorbed by substances that present a dark color. So we can use toluidine blue or something else like iodine combined with peroxide solution to irrigate the inner part of the pocket immediately after scaling and root planning with the traditional instruments. I mean, debriding the surface, the radicular surface, to remove the calculus of these areas. And then we will irrigate with these solutions, and we will apply these lasers at less than 1 bed of intensity, and we need to expect a reduction on the classical periodontal parameters like bleeding on probing, clinical attachment level. This means a gain in the clinical attachment levels, and also a reduction in the probing pocket depth. Why this occurs? Because thanks to the action of this photosensitizer, like this iodine solution or the toluidine blue, there is the presence or the creation of a sort of oxygen that is very reactive against the bacteria. It's called single oxygen, and it produces an oxidative damage and, moreover, a cell death of the bacteria that are in the inner part of the periodontal pockets. So here, this is another slide that I would like to show, that we need to irrigate the inner part of the pocket before irradiating with the laser to try to remove, to eliminate as much as possible the gram-positive but utmost the gram-negative bacteria. Now let's move to another indication, which is a non-surgical, still a non-surgical indication, which is the biostimulation. So the diode laser can also be used to treat these herpes lesions that can appear in the lips of the patient and in the skin of the patient. So the treatment with the diode laser reduces the length of the recovery time and the pain severity faster than the treatment with the classical or the gold standard acyclovir cream. This is how I do recommend to treat. So the light has to be in contact with the skin, and what it's doing, it's drying these vesicles that are created in the skin. And let me show you the fast recovery of the lesion only 7 days later. So this laser significantly decreases the dimension of the herpes and also the inflammatory edema. And this is how it looks 6 days later. And this is a picture of my lip. It's myself. I also would like to add that the recurrence of this sort of lesions, it's much less frequent whenever we use the diode laser than if we use some other sort of treatments like acyclovir. And let's move to the surgical indications. So the diode laser here represents an alternative to the conventional scalpel, to the electrosurgery, and also to the cryosurgery. So this good picker laser should be used around 450 nanometers of wavelength. In general, the classical diode lasers need to cut and coagulate. This means for the surgical indications to be activated like this, with an articulating paper or with a piece of wood like the one that I have been showing. The main difference with the good picker laser is that this laser doesn't need to be activated the very end of the tip of the laser, of the optical fiber. So we can cut and coagulate without this previous step. And let's move now forward the indications of this laser. So the first one is to remove the hyperplastic lesions that we can find in the oral mucosa, like this one. So traditional, we can use a normal bisturi and a scalpel, but if we use the laser, we can remove very fast. We can leave it healed on secondary intention. And after 1 week, 4 days, between 4 days and 1 week, this will be how it looks, the area treated with a diode laser. This means that we have a whitish area, that means fibrin. We need to say this, we need to say and to advise the patient that this is not pus, that this is an immature area of mucosa, that they do not have to remove anything. This is how it will be healing and along the time. Of course, we always need to go and analyze these lesions that a specialist is telling us what is it exactly. So the name and the surname of the lesion. I would also like to show you another another way of using this laser to remove lesions that we can find in the oral mucosa. So we can do a sort of resurfacing of the area, sort of peeling in some lesions that we cannot remove because they are that smaller that even with the surgical pinset we cannot take it with the surgical forceps. So you can also use it doing this sort of peeling or resurfacing of the area. You always need to have the suction because there is a smoke that is created, and we need to use the suction of the dental chair. Let's move to another indication. The following one are the frenectomies, and let's show you a nice video, real time, to show how can we remove these frenulums, the buccal frenulums, fast with very little bleeding, and with the same laser we can cut, and then when bleeding is starting, when we are passing the mucogingival line, we have more vessels in the area, we can go change the program to coagulation and coagulate the area. So it's very, very fast to do it with the diode laser, and we do not need to use any sort of sutures. What does the literature say? So if we use the diode laser to remove frenulums and some other mucogingival, soft tissue mucogingival problems associated with orthodontic treatments, we will need less infiltration of anesthesia. We will have reduced bleeding during and after the surgery. We will have, or we will expect, a rapid postoperative hemostasis, and we will not need at all sutures, and we will improve the patient's comfort and pain during the post-op period. This is another case, but this is how it looks immediately after cutting and coagulation of one of these frenulum lesions. We can also go and remove a lingual frenulum like this one, like the one that you see in the image. So in this case, we have been also cutting, coagulation with the laser, and in this case, I do recommend to place some resorbable sutures to avoid the painful post-op. Because here in this area, to have a post-op like this one, this fibrin and the area healing by secondary intention, it's very, very painful because the tongue is something that we use to speak, to talk, to eat, for everything. This is why this post-op without sutures in the lingual frenulum, it's quite painful. This is 7 days post-op in this kit, and we can compare the pre-op with the immediate 7-day post-op. This is another case that I did many years ago in a colleague. I didn't use the sutures neither at that time. This is how it looks 2 months after, and this is the mobility that he is gaining with the time in his tongue. He also went for a rehabilitation with another physician, but he's pronouncing better the words and he has a higher mobility degree in his tongue. Another indication, very similar to the previous ones, are the vestibuloplasties. And in this indication, the diode laser is also showing many postoperative advantages. So there is a lack of swelling, bleeding, pain, scar tissue formation, and also a good wound healing. So let me present you this case. This case was a patient that he had a palatal fissure when he was a baby. He was treated at that time, but he wanted to improve the root coverage of the second quadrant. One of the main contraindications to go for a connective tissue graft is to have a very low vestibulum depth. And this is what we had indeed in the area of the lateral incisor of the second quadrant. This is why before going for the connective tissue graft, we did first a frenectomy or a vestibuloplasty with the diode laser. And this is how it looks after cutting and coagulation with the diode laser. And 4 days post-op, we can see the typical fibrin formation in the area, which has a whitish color. And this is how it looks 2 months after, when we decide to go for a tunnel technique to improve this area, the root coverage of the area, and also to increase the horizontal thickness of the soft tissues in the lateral incisor. If you compare in the area of the lateral incisor, we first had more pink resin that we have in the immediate post-op. This is another case that I performed, that one of my residents, better said, performed a vestibuloplasty. We had this higher insertion of this muscle, and we needed to remove because we wanted to go after for a connective tissue graft. So we do a vestibuloplasty in the wall area of the incisors of the inferior mandibular incisors, and this is how it looks immediate after cutting, coagulation, and this is how it looks 7 days post-op. This, in general, the patient doesn't feel pain, even if he has this open wound that is healing by secondary intention. And this is how it looks 6 weeks later, where we have improved the depth of the vestibulum. And if we now decide to go for a connective tissue graft to improve the tooth number 41, this inferior incisor, to improve the root coverage, now we have the anatomical perfect conditions to look for it. This is how it looks in a more occlusal view. So let's talk now about why not to remove melanotic lesions of this area. This also can be done with the diode laser. I must say that most of the patients, they require at least 2 sessions, and this is something that we need to say to our patients. If you remember by anatomy, the melanocytes are cells that are included only in the external epithelium. This is why with the diode laser, we are going to do a de-epithelialization of the area. This is how it looks pre-op. This is how it will look immediately post-op and with the healing. I do recommend to preserve the marginal gingiva, that it's in immediate contact with the tooth, with the crown, this free gingival margin. And this is how it looks after the session of removal of these melanotic lesions. Another one of the indications is or are the crown lengthening in cases that we have especially delayed passive eruption, that we can diagnose this because we have in front of us a patient that has the shape of the crowns, it's not normal. It doesn't have the natural form or morphology of the gingiva. So the shape, it's like a small box. They look like this, these crowns, very, very short. So why does this passive eruption occur? Because during the phases of the dental eruption, we see the clinical length of the crown of the dentition because teeth are erupting, and when they reach the occlusal plane with the and by occluding with the teeth that are in the other maxilla or mandible, then the gingiva, it's moving forward the CEJ. When this does not happen is when we have this shape that we do not see correctly the crown and the perfect shape of the dentition of the crown. In cases that are diagnosed by this 𝐥𝐬 classification by 1A, this means that we have enough quantity of keratinized mucosa, and the distance observed in a periapical X-ray between the CEJ and the alveolar crest, it's between 1.5 and 2 millimeters, we can go to treat these problems. Because we like to recover by the crown lengthening with the laser this biological width that was described by Gargiulo. So with the diode laser, we can perform the gingivectomy in the class 1A. Let me present you this case that was done by one of my residents at the university at UIC. This case, it's a young lady, it's less than 18 years old, and this is when the definitive treatment of the delayed passive eruption must be done in girls and 21 years old in boys. So, as this is a young girl, we observed in the periapical X-rays that the alveolar crest was positioned at the CEJ. So this was not a class 1A. Nevertheless, we couldn't go to, the patient couldn't have a good oral hygiene, couldn't have it at home because of the shape of the crowns, and even the braces couldn't be placed in the correct area. This is why the orthodontist asked us for this treatment, and we informed the patient that very probably, utmost probably in the future, this patient should go for a crown lengthening with also including the osseous, the bony surgery. I mean to remove the bone in the alveolar to create the space between the CEJ and the alveolar crest of at least 2 millimeters. This is how it looks. The lateral view, observe that the braces are placed in an area that it's touching, that are in direct contact with the gingiva. So the first thing that we need to do is to calculate with the periodontal probe where the CEJ is located. Then we need to calculate how many millimeters of keratinized mucosa or tissue we will have. And then with the diode laser, we go and we shape the area. I do always recommend to first shape the central incisors, then the canines, and after doing this gingivectomy with the laser, in this tooth, we go for the lateral incisors. So as you can see here, we still have a good quantity or a good area of keratinized mucosa. We did the same in the mandibular teeth, and something else we did. What we did was not only a frenectomy, but also a gingivoplasty. That this means to reduce, by doing this sort of peeling, overlapping movements, we remove the thickness of the papilla. In this case, we also did a small frenectomy of this labial frenulum to place it in an area which is a bit more apically. So we did in the upper maxilla and also in the mandibular teeth the frenectomy, the gingivoplasty, and also the gingivectomy. And this is how it looks before, immediately after, and few days after, 15 days after. And this is how it looks after. The pre, if we compare with the post-op, this patient is gaining now space to mainly be able to clean correctly, in a good way, his dentition. Let's go for another indication. So we can do disinfection during socket preservation. This is a topic that I do love because many years ago I had the chance to collaborate in a chapter in a book, not only as an associate editor in this book in controversial issues in implant dentistry, but also in a chapter about socket preservation. So this technique allows us to preserve and to regenerate bone in these areas like the ones that I'm marking with these red arrows. So observe also the shape and the volume that the Schneider membrane has in this area. So after doing these techniques and also disinfecting the area with the lasers, we can achieve the disinflammation of the Schneider membrane, and also we can also gain this volume, and then this will allow us to place implants. Let me show you this case that we had this tooth that was scheduled for extraction, and we follow this protocol. We remove the tooth, we remove the granulation tissue, and then we disinfect inside with a iodine solution with peroxide 50% each, and then I do recommend to do an application of diode laser at 1.5 beds of intensity at a continuous wavelength. So this way we can improve the disinfection of the area. This protocol was first described by Dr. Isabel Sáenz de la Fuente from Spain. She has been also using this protocol for more than 20 years, having many, many good results. Then the socket is treated nowadays with LPRF, which is a concentrate of growth factors that are coming from the platelets. We combine with some biomaterial, and this bony block is placed in the alveolus immediately after disinfecting with the laser and this povidone iodine solution. This is how it looks in suture, how it looks 7 days post-op, and how it looks after 4 months of healing when we go to plan our implants. So this is a periapical X-ray, the before, the after, and this is how it looks, the cone beam tomography, the CBCT, in the area where we are planning to our implants, to place some implants. So compare the width that we have in the preserved area with the area that has not been preserved, which is in a more posterior area. And this is how it looks, the bone. So one of the main complications is to leave bacteria in the socket and to leave granulation tissue. And thanks to the laser, we can disinfect the area, and we can create, using the appropriate protocol, this bone that it's going to allow us to place the implants immediately after. Let's move to another indication, which is in periodontal regenerations. We can also use the tip of the diode laser to disinfect the most apical area of the defect, of the intra-bony defect, to remove the granulation tissue, but also to remove or to eliminate the bacteria, the gram-negative bacteria that are in these areas. Then we need to follow the protocol of periodontal regeneration. This is how it looks, the suture, few weeks after removing the suture, and how it looks immediately after, even with the splinting of the area to reduce the mobility, and how it looks years and years after doing this protocol. So thanks, one of the important things in regeneration is to remove the granulation tissue and to disinfect the bacteria, to disinfect the biofilm. So it's important to apply this sort of diode lasers as a main indication to remove the granulation tissue without damaging the remaining bony walls. Another one of the indications are the perimplantitis. So nowadays we have many devices, instruments to treat this sort of biological complications around implants. But years ago, we didn't have anything of the new devices that we are using nowadays. And I wanted to disinfect this implant that was asked me to keep it instead of removing like I did in the neighboring tooth that I was cleaning, I was preserving. So both areas where I removed the granulation tissue that was in the most apical area without damaging the buccal bony remaining wall that it's gonna serve me to as a bony wall to regenerate the area. Here I was covering with a dermal membrane. This is how it looks, the suture, and this is how it looks 5 years follow-up, 7 years of follow-up, the area, and observe that along the years, the implant that I was treating, that I was using this protocol disinfecting with a diode laser, it's still on place. These X-rays are not completely parallel, but the patient has been losing some other teeth, but after using a correct protocol of perimplantitis disinfection and regeneration about this implant, we can keep these implants along many years. Another similar indication is to treat something which is named retroperimplantitis that was first described by Dr. Mark Craven. There are some cases that we have due to an immediate implant that has not been correctly removed the granulation tissue lesion underneath. It also can be, we can also have this retroperimplantitis due to sort of necrosis in the area due to an overheating during the drilling while implant placement. So in this case, we wanted to keep the implant, we didn't want to remove, but we knew that we have this problem. It's a sort of cystic problem in the most apical area, and it was also creating a problem in the lateral incisor that needed an endodontic treatment. This is what a colleague did. So I went to disinfect the area. I wanted to remove the granulation tissue, which is in the most inner part of the implant. So I want to remove all the bacteria, to disinfect, to remove the granulation tissue before I place my regenerative biomaterials and before I cover with my membranes. And this is how it looks along the time. And everything was disinfected and cleaned with the diode laser. And let's go on to the last indication. And I always like to finish saying that only for this indication, I do think that it compensates to have a diode laser in our dental practice. So these hemangiomas are benign oral vascular lesions. They can be congenital or they can also appear during the years. So usually they are masses of a dark bluish color. So usually, or many years ago, 20 years ago, these lesions were removed with a surgical procedure that was taking about 1 hour. And by doing a couple of rotating flaps on the lip, nowadays we can perform, which is known as a transmucosal thermocoagulation or intralesional photocoagulation. So thanks to the use of the diode laser permits or allows us a safe treatment without hemorrhages. So nowadays, this sort of therapy could be named as the gold standard treatment for hemangiomas, because we can also consider or name that this is a minimally invasive surgical procedure. So first of all, I will show you what not to do. This is a vascular lesion. If I touch the area before it's coagulated, what I will have? I will have a bleeding. So here, if this occurs, you need to press the area to apply pressure, and then what you need to do, this is another example that was done in the correct way, is without contact with the hemangioma, close to the hemangioma, but without being in contact, you coagulate. You coagulate the area. It's starting to become a bit whitish, as you can see here, a bit whitish. And once this is whitish, has become white, we could touch the area, but never before, like I was showing you in the previous video. It's fast, and then this is how it looks 2 weeks after, without the need of using any sort of sutures. This is another case. This is how it looks immediately after. This is 1 week post-op. And this is another one that was done by my good friend, Dr. Isabel Saez de la Fuente. These are a couple of big ones, especially one of them. This is how it looks immediately after the thermocoagulation. Look, the one of the inferior lip, how it looks immediately after. There is a sort of scar formation, and then how it looks few weeks later. So for me, this is one of the main indications, because at least here in Europe, many patients are coming, adult patients, with this sort of lesions. And we can treat them in very few seconds without doing a major surgery in the lips. Saying this, I'm gonna finish the presentation. I would like to thank all you for being here today, and I'm very open now to any questions that I can answer. I would like to ask Olivia from Woodpecker if she could send me by WhatsApp maybe the questions, or if she can open the microphone, that I can go on answering you.
Hello, doctor. Okay, now we will end the live, and you can say goodbye to everyone.
Tell me, can you repeat, please?
Now we will end the live. 没有，它卡住了吗？No，我把它放上去了。